This is a 65-year-old female who's presented with a recent positive iFOBT through the National Bowel Cancer Screening Program. They have no bowel symptoms, no comorbidities or medical conditions, and no family history of colorectal cancer.
Let's use the Refer for Scope tool to support our clinical decision-making on whether this patient should be recommended a colonoscopy based on the clinical practice guidelines. The first selection we need to make is the age of the patient. We know this is 65. The patient has a recent colorectal cancer screening outcome, so we select immunochemical fecal occult blood test available and indicate that the result was positive. Based on this, the tool tells us that the guidelines recommend a colonoscopy, triaged in New South Wales as Category 1, with the procedure clinically indicated within 30 days.
So we have this person who's presented. They are willing and keen to undergo the colonoscopy. The patient has private health insurance, lives in a rural location, perhaps an hour away from the nearest regional hospital, and is keen to accelerate their access to colonoscopy. What might the referral options for this patient be? What factors, again, should be discussed as part of the decision-making process, and what key information should be included in the referral? Cameron, any initial thoughts?
Well, firstly, it's not one of the questions, but one of the things that you would never do in this patient is retest and hope for a negative. If they've got a positive, don't retest. You wouldn't have a leg to stand on. Their GP will understand all of those logistic geographic factors, and it won't be the first time they'll be guiding a patient of theirs through this. It will cost more, even if they find a no-gap colonoscopist. Most no-gap colonoscopists have no-gap anaesthetists, but they will still need to discuss the fact that they can't drive an hour to the nearest hospital. The logistics are the important things here, and be upfront in the discussion between the general practitioner and the patient. In terms of key information, positive fecal occult blood test, private patient. I hate to be blunt, but you don't need much more than that, except to mention fitness for propofol and medications.
So in terms of what should be considered, I think in this case, because it's a positive iFOBT as well from the National Bowel Cancer Screening Program, automatically means that a direct access colonoscopy service, if it's available, would be an option for this patient as well. The key factors to discuss, as Cameron mentioned, all of those different issues, the post-procedure discharge as well, and support arrangements where we've heard from people that they need to have someone with them after the procedure, and that can sometimes be a complication or something just extra to organise. And again, the key information, everything Cameron mentioned, and also because it's part of the National Bowel Cancer Screening Program, the GP assessment report as well via the National Cancer Screening Registry.
Eleanor, that's a great point about having a carer or someone at least to drive them home. The College of Anaesthetists for propofol allows next day driving, but most anaesthetists won't give patients a propofol anaesthetic unless there's a nominated person who's going to drive them home. And if they're elderly in particular, to stay with them until the next day. So they may only, if they're workaholics, they may only lose the 1 day of work, because there's no reason they can't go back to work the next day. And there's no reason, as I said before, that they need necessarily to take the day before off. They're on a white diet in the morning and some clear fluids after lunch, but they don't take the strong laxatives until 5 or 6 p.m. So it's a day off work for them, but it would be a day off work for the designated driver.
Chris, I'd like to ask you as well, given that the direct access colonoscopy is also a possibility here, because of the changes to the screening group, so that addition of 45 to 49-year-olds just recently in the last year, do all DAC services accept referrals for people who are under 50 if they have a positive test but have come through the program?
Yeah, that's a really good question. Actually, I've gone out to speak to them and check that to make sure I've got up-to-date information. So the clinics, by and large, have revised their criteria to reflect the new screening age, essentially responding to the risk profile of younger people, which underpins that change. And we expect that in addition to a few other changes, the next revision of the model of care, when it's refreshed in the medium term, will bring that age range up to date as well.
We did have another question as well, Cameron, is probably useful to address now. So should an iFOBT be done if a patient has 5 yearly colonoscopy?
It depends very much on the quality of their colonoscopy. I mean, all of you are aware that colonoscopy, apart from sedation complications, you can perforate, but that should be vanishingly rare. There's a 1 in 20,000 risk of bruising your spleen that can result in splenectomy. You can bleed if you take a polyp off. But by far the commonest complication of colonoscopy is missed polyps. Every colonoscopist in Australia has to recertify every 3 years. The main quality index is your adenoma detection rate. People who've got a very low adenoma detection rate but still scrape through recertification are probably missing more polyps than they're finding. So if you have confidence that the colonoscopist that you're referring to is high quality, and you should ask them, if you don't know, you should ask them, what's your ADR? Send me your figures. And if they don't, go elsewhere. Neither FOBT nor colonoscopy is perfectly accurate. What I would say, I didn't get a chance during the seminar, but there is no such thing anymore as having a 5-yearly colonoscopy. That's 20 years out of date. You shouldn't waste a clinic's time by saying, look, it's 5 years since their last scope. They have to have a valid current indication for colonoscopy. So 5 years, or they want, is not good enough.